Hello, anesthesiologists. Commuting to and from work in this cold weather must be very challenging. Please take care and avoid catching a cold.
Bonjour, chers médecins anesthésistes. Les trajets quotidiens par ce temps froid doivent être éprouvants. Prenez bien soin de vous et évitez d'attraper un rhume.
Namaskar, माननीय anesthesiologist डॉक्टरों. इस ठंडे मौसम में काम पर आना जानवास्ता में काफी कठिन होगा. कृपया अपना ध्यान रखें और सर्दी से बचें. All right, today we're going to dive into a really fascinating and complex case that sits right at the intersection of hematology, hepatology, and of course, our world, anesthesiology. We're looking at the formidable challenge of managing a living donor liver transplant in a patient who has the dual diagnosis of Budd-Chiari Syndrome and Antiphospholipid Syndrome. Now, this is a scenario that really pushes our understanding of hemostasis to its absolute limit.
So here's how we'll break it down today. We're going to start by building a really solid foundation, exploring the pathophysiology and management of these two core syndromes. Then we're going to put that knowledge to the test. We'll look at a really challenging pediatric case, and we'll walk through everything. The preoperative assessment, the dynamic intraoperative tightrope walk we had to perform, and of course, the crucial clinical lessons we can all take away from this incredibly complex anesthetic.
Okay, first things first, let's establish our framework by really defining the two conditions at the heart of our case. That's Budd-Chiari Syndrome and Antiphospholipid Syndrome. I mean, understanding each one of these individually is the critical first step. Only then can we really appreciate why putting them together creates such a uniquely dangerous clinical puzzle. So let's start with Budd-Chiari. The easiest way to think about this is as a critical plumbing problem for the liver. It's essentially a dam in the river of the hepatic venous outflow. So whether it's a clot in the small hepatic veins, the major ones, or even the inferior vena cava, the result is exactly the same. Blood can't get out of the liver. This leads to this massive sinusoidal congestion, which causes ischemic injury to the hepatocytes. And this is what gives us that classic clinical triad you see: abdominal pain, ascites, and hepatomegaly. Left untreated, this whole process just progresses to cirrhosis and ultimately end-stage liver failure.
And this image, this CT scan from our actual case patient, just brilliantly illustrates the real-world consequences. You can so clearly see the massive enlarged liver. That's the hepatomegaly. And that dark fluid you see surrounding it, that's the ascites. The patchy, kind of uneven appearance of the liver tissue itself, that's a classic sign of the severe venous congestion and the damage it's causing. And if you look right in the middle, you can see that bright metallic glint of an IBC stent. That was a prior intervention, an attempt to bypass the obstruction, which, as we're about to see, eventually became part of the problem itself. Now, in complete contrast to the plumbing problem of BCS, antiphospholipid syndrome is a sticky blood problem. This isn't a structural issue at all. It's a systemic, acquired autoimmune disorder. What's happening here is the patient's own immune system is producing autoantibodies that go on the attack, targeting phospholipids on cell membranes. This pathological process just completely disrupts the body's natural anticoagulant mechanisms. It activates endothelial cells and platelets, and it creates this relentless, profound hypercoagulable state that can cause devastating clots absolutely anywhere in the body, both venous and arterial. And these are the three specific culprits we test for to diagnose APS: lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. Their presence is what drives this profound hypercoagulability. It's their interaction with the coagulation cascade, specifically by messing with natural anticoagulant pathways like the protein C system, that relentlessly promotes thrombosis. And, as we're about to see, that first one on the list, the lupus anticoagulant, is also responsible for a major diagnostic paradox that is absolutely critical for us as anesthesiologists to understand.
So when you're faced with the plumbing problem of BCS, how do you actually approach treatment? Well, it's not an immediate jump to a massive surgery. The management really follows a structured, stepwise process. The goal is always to restore that hepatic outflow using the least invasive method possible.
So management always begins with medical therapy. Primarily, that means systemic anticoagulation to prevent the existing clot from getting bigger and to stop new ones from forming. If that fails to control the symptoms, or if there's a really discrete narrowing, the next step is to call interventional radiology. They can come in and do things like angioplasty, stenting the veins, or maybe creating a TIPS to decompress that portal system. Now, if these less invasive approaches fail, then surgical shunts can be considered. But for patients with decompensated cirrhosis or fulminant hepatic failure, liver transplantation becomes the final definitive solution. And it's important to know, our patient had already failed steps 1 and 2, repeatedly.
It's also really crucial to distinguish between primary and secondary causes of Budd-Chiari. Think of it this way. Secondary BCS is when something outside the vessel, like a tumor, is physically squeezing the pipe shut from the outside. Primary BCS, which is actually more common, is when the problem originates inside the vessel, like a clog in the pipe. And this is almost always driven by some underlying hypercoagulable state. Conditions like polycythemia vera are major culprits. But right there on the list, and a very common cause, is antiphospholipid syndrome. This is the direct, devastating link that brought these two diseases together in our patient.
Okay, let's move on to one of the most interesting and, I think, clinically vital points for us as anesthesiologists, the paradox of coagulation testing in antiphospholipid syndrome. This is a situation where the laboratory findings can be dangerously misleading if you don't interpret them with a deep understanding of the underlying pathophysiology.
This is a classic board question, but it's also a very real-world clinical puzzle. You've got a patient with a documented history of severe, life-threatening clots. You know they are profoundly prothrombotic. Yet you get back their labs and the activated partial thromboplastin time, the APT, is prolonged. It suggests they're anticoagulated. How in the world can this be? So the crucial point here, the absolute takeaway, is that this is an in vitro artifact. It's something that happens in the test tube, not in the patient. See, the APTT test relies on phospholipid reagents to kick off the clotting cascade in the lab. In a patient with APS, the lupus anticoagulant antibody in their plasma binds to these phospholipids and literally interferes with the assay, artificially making the clotting time look longer. But in vivo, inside the patient's body, that same antibody isn't inhibiting clotting at all. In fact, it's causing it by disrupting natural anticoagulants like protein C and activating the endothelium. So relying on that prolonged APTT to guide therapy without this critical context could lead you to withhold necessary anticoagulation, and that could have absolutely catastrophic consequences. Okay, so with that foundational knowledge, let's apply these principles to our actual case, a 16-year-old female who presented for a living donor liver transplant. Her history is a real testament to the severity and the relentless nature of her combined diseases. So, as you can see from her extensive history, this was a patient with a truly relentless, refractory prothrombotic state. Her diagnosis of BCS was a direct result of her underlying APS. She'd already suffered multiple systemic thrombotic events, including a PE and end organ infarctions in her spleen and kidneys. Surgeons and interventional radiologists had tried everything: angioplasty, multiple stents, thrombectomies, but her APS was just so aggressive that she repeatedly formed clots within her IVC stent. The final straw was the complete thrombotic obliteration of that stent, which led to intractable liver failure and left transplantation as her only remaining option. Now, her pre-operative labs show this classic picture of liver dysfunction. You see the INR is up to 2.07, which immediately makes you think, okay, high risk of bleeding. But here's where it gets incredibly complex. Look at the specific factors. Factor 5, which is synthesized only in the liver, is low at 65%. That fits the picture of liver failure. But factor 8, which is synthesized extrahepatically, is totally normal at 113%. This is a key feature of end-stage liver disease, what we often call rebalanced hemostasis. And on top of that, her protein C, a natural anticoagulant that also comes from the liver, is low. So what do we have? We have a patient with a high INR, suggesting bleeding risk, but also high levels of a key procoagulant factor and low levels of a key anticoagulant, all superimposed on her baseline severely hypercoagulable APS. This is the hemostatic nightmare we had to manage. This thoracic surgery consult was an absolutely critical planning point. Given how extensive the thrombosis was, there was a major concern that the surgeons would need to put her on cardiopulmonary bypass to do the reconstruction. Now, for an anesthesiologist, putting a patient with APS on bypass is a terrifying prospect. The systemic heparinization, the potential for heparin resistance, the massive inflammatory response from the circuit, and then the subsequent protamine reversal, all of it adds just immense risk in a patient who is already primed for thrombosis. So the finding of extensive collateral circulation was this huge ray of hope. It suggested that the IVC reconstruction could potentially be performed without CPB, and that became a central goal of the entire anesthetic and surgical plan.
Okay, so now let's move into the operating room and see how this all builds into the ultimate anesthetic challenge, walking this incredibly fine tightrope between massive hemorrhage from portal hypertension and all the surgical dissection and catastrophic graft thrombosis from the underlying hypercoagulable state.
This operation was a true marathon. It lasted over 14 hours. This timeline here breaks down that journey. After induction and securing extensive monitoring, we're talking 2 arterial lines and a Swan-Ganz catheter, the pre and hepatic phase began. This is where the battle against bleeding really starts. It's characterized by major blood loss from dissecting all these dense adhesions and engorged collateral vessels. At 1:30 in the afternoon, the diseased liver was finally removed, and the anhepatic phase began. This is the period of the greatest physiologic instability, with no hepatic clearance of metabolic waste and complete IVC occlusion during the reconstruction. Then, at 3:30 p.m. came the moment of truth, reperfusion, which is always fraught with risk for hemodynamic collapse. The surgery finally concluded at 11 o'clock at night.
Now, what's really interesting about this slide is how it tells the physiological story of the surgery in numbers. Just look at the column for the anhepatic phase, T3. The INR jumped to 2.13. Fibrinogen plummeted from a healthy 356 down to a critical 146. Platelets dropped by 2/3, and the liver-dependent factor V crashed to just 19%. This is a picture of catastrophic coagulopathy from massive bleeding, consumption, and dilution. But now contrast that with factor 8. It also drops, but by the end of surgery, it has rebounded all the way back up to 119%, while factor V remains profoundly deficient. This again highlights that persistent prothrombotic potential lurking underneath. And you can see the physiological toll in the metabolic acidosis, with our lactate peaking at 6.2 and the base excess dropping to nearly -10 post-reperfusion. The scale of the hemostatic challenge that we just saw in those lab data is really reflected in the sheer volume of blood products it took to keep this patient alive. We administered 13 units of packed red blood cells, 16 units of fresh frozen plasma to try and replace those coagulation factors, 4 apheresis units of platelets, and a massive 20 units of cryoprecipitate, specifically targeting that critically low fibrinogen level that we just saw. This was a true massive transfusion protocol, guided in real time by lab data, all in an effort to walk that fine line between exsanguination and thrombosis.
So, after navigating this perfect storm for 14 hours, what did we actually learn? Let's take a minute to distill the key outcomes and the clinical lessons that we can all apply to our own practice when we're faced with these extraordinarily complex patients. You know, the initial postoperative course was remarkably successful. The patient was weaned from vasopressors and extubated on the operative day. She was transferred out of the ICU on postoperative day 3 and was actually discharged home on day 19. It's really a testament to the success of the intraoperative management. However, the story doesn't end there. 6 months later, despite being on anticoagulation, she developed a recurrence of her IVC thrombosis. This just powerfully highlights the persistent and formidable nature of her underlying antiphospholipid syndrome. The transplant fixed her liver, but it did not cure her autoimmune disease. This slide really summarizes the central conflict that defined the entire anesthetic. On one side of the tightrope, we had an immense risk of bleeding. This was driven by the portal hypertension, the massive surgical wound, dilutional coagulopathy, and the lack of liver-synthesized factors like factor V. We managed this with aggressive, targeted transfusions. But on the other side, we had an equally potent risk of thrombosis, driven by the patient's APS, her elevated factor VIII levels, and the surgical stasis. This was managed by a meticulous surgical technique, that crucial avoidance of CPB, and a carefully planned transition to lifelong anticoagulation. Literally, our every action had to be weighed against its potential to tip the patient toward either uncontrolled hemorrhage or a fatal graft thrombosis. This case, I think, powerfully underscores the limitations of our conventional coagulation tests. An INR of 2.0 suggests bleeding, but we know the patient is pathologically thrombotic. An APTT might be prolonged, but we know it's just a lab artifact. This really points toward a future where real-time, goal-directed therapy guided by viscoelastic tests like ROTIM or TEG is not just beneficial, but is truly essential. These tests give us a global picture of hemostasis. They assess clot formation, strength, and lysis in real time, allowing us to more precisely tailor our transfusions and to truly navigate the incredibly narrow therapeutic window that exists in these most complex and challenging patients.